Welcome all, and thanks for all the people who have taken time out to join this very interesting webinar. And especially, I think last week when we were discussing about Almaty conference, I think community health worker and community health per se was one of the main discussion points, and especially how it should be resilient enough to address all the emergencies and experience. So we are very fortunate to have Nache and Sergey with us to share their experience from the 7 countries. And to the people who are yet to join the community health community of practice, we will like you to be part of this forum or this platform, where we really look forward to South-South collaboration in terms of sharing of good practices, case studies, and primarily sharing, solving, and learning that we aim to do it. So I will request, I think we have now 70 attendees with us. So most of us know this platform, but those who don't know the platform, I think at the end of this presentation, we will share with you the link. So please do join and share all what you have been doing in terms of in the respective countries, how you are improving community health and linking with primarily to the primary healthcare and overall health system.
Thanks a lot, Sangeeta. So we hope that you will join the community health community of practice on collectivity. So at this stage, we are about to start this webinar. So I'm in Antwerp here. So I'm Bruno Messen. I'm health economist and work in the Department of Public Health. I'm involved in the collectivity platform. So today we will have 2 speakers. We come, I think, with a very important topic, and we are really grateful to our friends of UNICEF to bring this topic. We have been with the Community Health COP working now for nearly 1 year on community health workers. We have considered different settings like Bamako, for instance, or other situations. But here it will be really focused on emergencies and humanitarian settings. And we are lucky to hear 2 speakers who will present experiences from 7 countries. So we will have first Nate Miller, who works with UNICEF and based also at the Columbia University. Nate will present 5 situations in 5 settings. So 3 countries affected by the Ebola outbreak, and then South Sudan for a situation with conflict, and then Bangladesh for natural disaster situation. And then we will have Sergio Lopez. So Sergio is a registered nurse with a master's in health and development. He has been working in different situations in low-income countries, and then he will report a case study carried out in Central Africa, and more precisely in Chad and Republic Central Africa.
Great, thanks so much. Thanks everybody for joining. Happy to be presenting this to you, and especially to representatives from the countries that may be hopefully implementing some of this work in the future. So yeah, the topic of this presentation will be community health and emergencies. As Bruno said, we're looking at 5 country case studies that we conducted. So to start out with, the reason for starting this work in the first place was that there's an idea, first a question of how do we increase resilience during emergencies? So how do we improve health system resilience and resilience in communities when emergencies happen? So there in 2011, this joint statement of UNICEF, UNHCR, WHO, and others was published promoting scaling up a community-based health workforce in emergencies and putting forth the idea that community-based responders and health workers are best placed to respond to emergencies and to continue services because they are in the communities already, so they'll be the first responders. And there's been a lot of anecdotal evidence of this. For example, in Pakistan and Myanmar and several countries that have had natural disasters or other emergencies, there were stories about how community health workers were the first to respond, but there was not a lot of rigorous evidence about this. So we wanted to try to do a bit more rigorous data collection in some of these settings to try to really provide evidence and see what actually happens during these emergencies. So we did the 5-country case studies. All of these were focused on community health workers. They were providing community case management or other maternal newborn health services. In all of these cases, the programs were supported by NGOs, and there were different types of emergencies. So we wanted to look at different settings with conflict, natural disaster, and disease outbreak. So the objectives of the studies. So the first thing was to document the effect of the emergency on the functionality and utilization of community-based services. The second point was to document and assess the contribution of CHWs to emergency response. So one point is looking at the ability to continue routine services, and then the second point is how did CHWs help in responding to the emergency? And then finally, to document the lessons learned and recommendations for early recovery, health system strengthening, and building health system and community resilience in the future. So the methods, they were retrospective case studies, so we collected data after the emergencies. Again, focused on community health workers providing community case management and other services. We looked at some urban and peri-urban areas, but mostly rural communities. It was mainly focused on qualitative data collection, but we also analyzed trends in routine program service data. And there were common protocols and tools across all of the country case studies. So we did data collection in Guinea, Liberia, and Sierra Leone for the Ebola context. In these countries, we looked at 4 districts per country. In total, over the 3 countries, there were 124 interviews, 78 focus groups, and a total of 582 participants. And these data were collected and analyzed by a private research firm called Anthropologica. In South Sudan, we were looking at the conflict that started in December 2013. We looked at 1 affected district, 20 interviews, 13 focus groups, and these data were collected and analyzed by IRC, International Rescue Committee, and UNICEF. And in Bangladesh, we were looking at seasonal flooding situation. And again, we looked at 1 district, 28 interviews, 13 focus groups, and Save the Children conducted this study. So now getting into the Ebola setting, first looking at the routine community-based maternal newborn child health services and continuation of those services during Ebola. So we found that for the most part, when Ebola hit, the community health workers that were already in place, they did continue working as much as they could. So they continued providing their services in the community as long as they had the drug supplies. They continued their community mobilization activities and their community education activities, and even adapted these on their own to the Ebola context. With regards to ICCM, it's really reliant on having the drug supplies and getting the supervision. So it really depended on policy and support from the government and the supporting NGOs. And there was a lot of confusion over the no-touch ICCM policy. So the government had enacted this no-touch policy to continue ICCM without touching the patients. But there was a lot of confusion about this, and a lot of people understood that they were told to stop ICCM altogether. So a lot of programs stopped treating children because they were under the impression that they were supposed to stop this. So there's a lot of confusion there. The maternal newborn health services didn't rely on actual treatment. So this was just going house to house and screening newborns and pregnant women and then referring them. And these services largely continued. There was largely reduced utilization of services of the community health workers. This was due to the widespread mistrust of health workers and the health system, and the fear also that CHWs would refer people to a health facility, and people were really scared to go to health facilities. So the CHWs faced a lot of this mistrust because of their linkages to the health system. So we saw a lot of increases in home treatments and traditional medicine. So when people preferred not to go to health facilities or sometimes even to see the CHWs, then they instead just did home treatments or they went to traditional healers. So even though the CHWs faced a lot of stigma because of their links to the health facilities, they did tend to be more accepted than the health facilities. So this quote just points this out from a community leader in Guinea. He said, "During the early time of the outbreak, we kept our distance from our CHW because of fear driven by the suspicion that our CHW might have been given some chemicals or drugs that he may put in our well water with the goal of infecting the entire population in the village with Ebola. After some time, we came to understanding that our CHW was our son. His mother and father are here. He was born here and his family would be amongst the victims. So based on this analysis, we decided to come back to him and work together with him to stop the spread of Ebola." So this really highlights the difficulties that CHWs faced. A lot of them reported facing a lot of stigma and harassment and hostility from community members because of this mistrust. But then on the other side, they were better able to overcome this mistrust because of the relationships they had in the community, as opposed to the health facility workers who really had a difficult time to overcome this mistrust. So this is looking at the routine quantitative data. So we see the different services. The blue line is the ICCM treatment, and we see the gray shaded area is when the outbreak was highest in the study areas. So we see that during that period, services, the number of children treated did decline quite a bit, but then recovered near the end, even at the time when Ebola was still active in many of the areas. And then if we look at the green line, so this is the home visits for antenatal care and postnatal visits, and that actually stays about the same as before Ebola or even increases a little bit. So I think this highlights that the CHWs remained active, but the drug supplies and the policies for ICCM were really a challenge. So that was from Sierra Leone, the first one. The second one here is from Liberia. We only got data from one of the counties here in Bong, and we see a similar but maybe even more dramatic scene here. So when Ebola hit, the services, the ICCM services and also immunization basically drops to near zero for some period of time. So this was because the CHWs were basically told to stop. And then when they were told to start again, the services quickly recovered to where they were before. So we also looked at the TBAs, the traditional birth attendants and traditional healers, and their activities during Ebola. So both of these actually increased their activities during Ebola. You know, this was informally because they are working more informally in their communities, and when people stopped going to facilities or CHWs, then they increased their utilization of TBAs and traditional healers. So most women were unwilling or unable to go to health facilities to deliver, so they were being delivered in the communities by the TBAs. Despite this, the TBAs were not supported for this, and most of them had never received any protective equipment. So this created a very dangerous situation for the TBAs and for the mothers. Some of the TBAs did get some training on infection prevention and control, but this occurred quite late in the response. So it was really, they were engaged too late in this. And the traditional healers also were not really engaged or trained. Some of them just at the end of the outbreak, they were trained on infection prevention and control. So now this is looking at the Ebola response, so not the routine activities, but what CHWs actually did for Ebola response activities. So the engagement of community actors came late in the response. The initial response was to train people from outside and send them into communities to deliver Ebola messages and try to find possible cases and refer them to facilities. And these outsiders were really mistrusted and rejected by communities. I think we all heard stories of health workers being attacked and ambulances being burned. So this response was really not very effective. And eventually, they did decide that the way to do this was to engage the people from the communities. And they started engaging the CHWs heavily. And eventually, the CHWs were carrying out social mobilization, contact tracing, active case finding, and caretaking activities in the communities. The caretaking was basically when people were sick and waiting for ambulances, the CHWs would keep an eye on them, bring them food, water, make sure they were okay, these kind of things. So the real key, all of the respondents at all levels of the study highlighted that it was really the engagement of community actors that was key in changing community attitudes and improving community compliance. So this refers to the CHWs, but also it was very important to engage the community leaders, the traditional leaders in the communities, and community health committees when they were already active in communities. And this was really the key to reaching community members. So there's a quote here from a national level stakeholder in Guinea who says, "Many community workers that were chosen outside the communities were beaten and chased away. But when we selected CHWs from within the communities, they were accepted and our messages were accepted since these CHWs were trusted family members. Through the CHWs, we were able to locate and get hold of suspected Ebola patients who had run away out of fear because they are part of them as family members, making it easier for the CHWs to know where they had hidden themselves." And again, looking at the TBAs and the traditional healers, they were not really engaged in the Ebola response either, so they were not supported on their routine activities, and they were also not really engaged in the Ebola response, so this is possibly a missed opportunity here. So now moving on to the South Sudan setting. So again, we were looking at the conflict that broke out in December 2013 and continued on into the first half of 2014. So the IRC staff, when this conflict broke out, the IRC staff, the international staff were evacuated, and initially the CHW services dropped, so there wasn't a lot of initial contact between the IRC program and the CHWs. A lot of the CHWs were displaced with their communities, so there was some lack of contact and drop in services. However, we did find that the CHWs generally moved with their communities. If they were able to bring their drug supplies with them, they would continue treating people when they moved. And we found cases where CHWs had moved into host communities, or the most common situation was that CHWs were in communities that received displaced people into their communities. In both cases, they said that they did continue treating people, both from their original community and from the new displaced or host community. In terms of how to find these people and provide them with new drugs, the supervisors in this program in South Sudan were also community members. So they used their social networks. They would go around and ask around, where did these people move to? Where were they displaced to? And then they would track them down where they had gone and then meet the CHWs there to provide new drugs. So there was some delay in this, but it did work fairly well over time. So there's a quote from a CHW. "We were with new people where we ended up, and we continued giving our services as CBDs, community-based distributors. Those new people also appreciated our services. They did not want us to return home." So in the communities where CHWs were in host communities that received displaced people, there was a large increase in the population in those communities and in the number of people who needed treatment. So it was difficult to fill that demand when the population increased so quickly. But we did find that CHWs treated many more people than the health facilities. So this graph, again, looking at the number of ICCM treatments given by the CHWs. So the yellow line here is basically looking at the number of treatments per population of children. And we see in the gray line, in the gray shaded areas, when the conflict happened, that the number of treatments dropped considerably, but then quickly within a couple months recovered and eventually reached its original level. So that's basically tells us about the number of treatments given, because we're keeping the population the same here. If we look at the blue line, it's taking into account the new IDP population. So with the increased population because of the IDPs, this line shows us that they were not really able to meet the demand of the new population that came in. And then the green line is the health facility treatments for sick children under 5. And we see that this was quite low and much lower than CHW treatments, both before the emergency, during the emergency, and after the emergency. So now moving on to the Bangladesh setting. So this is looking at seasonal flooding. And we found that when the floods hit in Bangladesh, it reduced access to services. So normally the CHWs were providing services in a fixed clinic, but they were unable to do this. A lot of people couldn't reach the clinic when the floods were there. So the CHWs, they continued providing their services. They were willing to provide the services, but because people weren't able to reach them as easily, the caseload decreased. In response to this, the CHWs decided on their own to travel to reach households or to set up temporary clinics in areas that were more accessible to people. So here's a quote from a CHW who says, "I could not provide treatment from the community clinic because they could not come here. I communicated with the community groups and discussed with them about this. I took the permission to sit on a specific house and inform the community through the speaker system. They arranged a small boat for me so that I could move or go to the place where there was an immediate need." So this just points out that there wasn't really planning on what to do ahead of time in this situation. So it was the CHWs along with some community members sort of improvising at the time. And the supervisors were able to reach the CHWs because most of them had cell phones and they were able to reach them by phone network. They improvised by moving and setting new clinics. They used boats to move around the community. So it was really an ad hoc response, but it also shows, well, it shows one, the lack of planning, I think, but it also shows the motivation of the CHWs to continue providing their services during the emergency. So there were two types of CHWs. One is CHCPs, community health providers. They're government CHWs, and they worked in the clinics. And then there are village doctors who are private providers, and they're a bit more flexible because they buy their own drug stocks, and they actually proved to be a bit more flexible than the government CHWs because they anticipated the heavy rains and the flooding, and they bought extra drug stocks and found safe storage ahead of time, whereas the government CHWs had less flexibility to do this. So looking at the routine data, the blue line is the government CHWs. So they provided the most treatments, but we did see a sharp decline in treatment during the emergency and then some recovery. The green line is the private providers. So there's some drop here, but maybe less sharp of a drop in the private providers. And then the yellow line is just the sum of both types of CHWs. So just to sum up some lessons learned from these case studies. So one, I think the important point is we have shown from several different types of settings that CHWs can provide their services, continue providing their services when emergencies hit, and they, for the most part, seemed very eager to do this, to continue providing their services. They were able to access displaced and hard-to-reach populations. We found that really using local actors, including the CHWs, but not limited to the CHWs, also local leaders and community groups, are really key to an effective response. However, they do need continued support from governments and NGOs. We can't assume that they can continue providing these services on their own, especially in a situation for services like ICCM, where they need the drug supplies. There has to be this continued support from the government or the NGO partners. And they also need clear guidance on the policies. What should they do about continuing services during the emergency, and then operational strategies. So for example, the no-touch ICCM policy was created during the emergency response, and there was a lot of confusion about this. So ideally, these operational strategies and policies will be worked out ahead of time. So planning for these predictable crises in terms of doing some preparedness planning and knowing what your contingency plans are during the emergency. In many of these cases, certainly in Bangladesh, and I would even argue in the case of South Sudan, we may not know exactly when and where an outbreak of violence is going to happen, but we can expect that it is going to happen in many areas of the country, so we should be planning for this. And then finally, we just need more guidance on how to do this better, and gathering the lessons learned and providing some more evidence on how to provide community health services during emergencies, and getting some more evidence of impact. So these studies are really the first part of a larger project that's going on. So we're continuing to provide some evidence from field studies and also working on a literature review on community health and emergencies So we're continuing to build on this evidence with the goal of eventually producing some of this guidance. So please stay tuned to this, and we'll share evidence as it becomes available. So thank you so much.
Good afternoon or good morning, everyone. Thanks for inviting Mentor to this webinar. Very interesting, and I would say that following Nathan, there will be a lot of messages that will repeat. So you know, forgive me if some of the messages sound familiar, but clearly some of the points that were touched before are pretty much aligned with what I am about to present. So I'll just give a very brief presentation on Mentor programs in CAR and Chad. As you know, CAR has been over conflict for a long time as well, and Mentor has been working in CAR, implementing community health programs for a long time as well. And during the last year, we have shifted our programs to adapt to this new context. Maybe not that new, but we started to understand better that to provide a community response, we would need to adapt the program. So I'll just do a quick overview of Mentor approach, and then just highlight some of the key challenges and some of the answers we found out. So I will not bother you too much in explaining what happens in conflict situations when the most basic services are depleted and there's a total disruption in health services provision. And I mean, linked to that, also population movement, increase the exposure and so on. And most of the times, these community health workers approach, these community programs are potentially the only viable option. So that's why Mentor came up with a lot of these programs in several countries where we operate. And it's not just a quick fix for a problem. We don't see it that way. It's really because despite the fact that it's possible to provide these services at community level in the most remote places where there's no services available, it's really because we believe that community approach can bring an extra value that potentially just the common services in this kind of conflict-affected situations cannot provide. So, you know, when there is no staff, no structure, no supplies, and obviously people can't move because there's natural barriers or because it's an ongoing conflict, potentially the only viable solution is through the selection and training and supervision of community health workers that can provide care to their communities. So we have been doing this for a while, as I said, and we give a lot of attention to the selection, and this is a community of practice on community health. So I won't go too deep on the selection process and so on, because I believe most of us are aware of the importance of selecting people within the communities. But we give this first stage a lot of importance because we really want to ensure acceptance. And as Nate said before, it's really important for communities to accept the community health workers they select, and to ensure that then the care they provide is effective. Otherwise, people will just run from the only healthcare provider in a radius of several kilometers. So we take a lot of care in selecting people by empowering the community to select a person that everybody agrees. And sometimes this process takes time, but it's really effective at the end. Another very important point that was touched before is that this person needs to be from the community, not just to fulfill a criteria. It's really because in these conflict situations, some of these community health workers, or most of these community health workers, they move along with the population. And this kind of link that exists between the community health worker and the population they serve was the basis of a project that I will talk later on, because we need to target also the health of the populations while they are on the move. And if this community health worker doesn't move along, then this contact, this health service provision is lost during the time that the communities are running from the conflict. So, but recruitment is not the only step. We need to ensure training as well, and establish supply chains of drugs and RDTs, because as it was explained before, these community health workers, they keep working with their community as long as they still have drugs and RDTs. In this case, we're talking about CAR and Chad, where they are able to test and treat for malaria in this case. But it's hard to rely on local supply systems. So sometimes we need to do it ourselves, as you can see in the picture. And this is a very, very important step, because you need to calculate the quantities you need for a long period, plan for the rainy season, and now you will ensure that these community health workers will have enough stocks to sometimes be without a supervision for 1 month or 2 months, so without supplies for 1 or 2 months. So this planning stage is really important. And of course, one of the key aspects of our work is also to ensure supervision. And the supervision is not only to provide drugs, and that's a very important step, but it's also to assess the community health workers' capacity to provide quality of care. So we are not trying to provide simple and basic care without quality. We also want to ensure that even in very hard scenarios, these community health workers are supported to provide quality care. Another very important issue that we have been finding is this data, routine data collection, and I will give you a very simple example in a minute. It's really important to ensure that we are able to identify some of the trends, and sometimes identify an outbreak in advance, or some epidemiological trend that is not captured through the health facilities in the nearest city or something like that, because people just can't reach these health facilities. So just as one slide on an article that Mentor published last year about the CAR program, and Nathan was talking about impact assessment, even though we can discuss about the impact assessment measures. But this is a clear presentation of that community health worker programs are possible even in emergency scenarios, and they can be supported through a long period of time, even through conflict, as it happened with mentoring and CAR. And when we look at the last point in this slide, you can see that during these 5 years, more than 160,000 malaria cases were diagnosed and treated by community health workers. So we wonder, in this kind of context, what would have happened with these people that potentially would not have access to any healthcare provision. So we were talking about key challenges, and of course the main challenge is when you have conflicts and you have whole villages burned down to the ground, is to ensure that you can trace these community health workers, that they flee, of course, and also the population, you just lose contact with them. So in this case, our experiences tell us that the best approach is really to try to connect again with community health workers, either through the contacts we have, but sometimes you need to go through local leaders or neighboring communities. So, but Mentor in the past couple of years, particularly in CAR, these conflicts have displaced whole villages, and we do a big effort to get in touch again with these community health workers and reestablish contact. As you can see here in this graph, also from the same paper, the bars represent the community health workers proportion that stopped reporting, and of course after a coup, d'etat, this proportion increases. But we can later on go back to the rates we had previously, which means that we can reestablish contact with them either through community leaders, either through getting in touch with these community health workers again. And in some cases, these community health workers, they come to our offices directly and ask to be supported. So it's a mix of these kind of strategies that ensure that the continuum of care for these populations. In some cases, we just lose completely contact with them, so we need to retrain and sometimes select new community health workers if it's needed. Of course, there's other level of challenges in this kind of context. I'm pretty sure you imagine that supplies and access to community health workers to ensure supervision is very, very challenging. But also in this case, we need to be very creative. The challenges are not only operational. Nathan referred some of them. I guess one of the key challenges in CAR and in Chad is that community health workers we end up selecting are potentially some of the most knowledgeable in their villages, but their baseline educational level is really, really low. So there's a very, very strong component in supervising these community health workers' work on a monthly basis, sometimes bi-weekly, to ensure they are following up guidelines and to ensure quality of care. Then it's also about adapting the programs to local context. In some countries, community health workers can do a category of activities, while in some others they can. And sometimes it's really challenging to see the needs are asking for a broader approach, but the local programs don't allow to do some sort of treatment or some sort of activities. But of course, and this leads to what I'm about to present of our latest project. The major challenge in conflict situations is really when the whole population disappears from one day to the other, and when the community health worker disappears. So recently, well, a year ago, you probably heard there was a big conflict in Northern Central African Republic, in this region of Oampende. And a lot of villages where mentor work just ran in a week or two. The whole village disappeared. And some of them, they flew to Pawa, but some of them flew to Chad. So we were able to respond in Pawa, where we have a base. And as I was saying before, some of these community health workers came to our office. They asked for support. We responded in several ways. We also set up some mobile posts with this community health worker support to mobilize community, the whole displaced population. But we were finding out that we were not responding to the needs in the Chadian border. So to these refugees that were running to Chadian villages, and they were not necessarily settling in refugee camps, but they were here in this region along the border in several villages where these communities have families, so it's natural that they end up setting up there. So we found out that we would need to respond not only when the populations were settled in their villages, but also when they were on the move and when they were arriving here. So we designed this cross-border project to respond to this kind of situation, so to work somehow on preparedness plans and preparedness activities that would allow us to respond quickly and effectively to massive displacements. So this cross-border project, I would say it's still embryonic, but we are now implementing activities to make it happen, because also in this region there's a regular seasonal movement of the population due to transhumance from south to the north during this time of the year, in fact, and then back again. So, sorry. So we would need to respond this and to set up a program that would respond to this kind of needs. And we need to obviously design activities not only to plan for the program, but also to respond later on. So the first stage of it is really to adjust curriculums on both sides. And we realize that if you train community health workers on CAR, potentially then in CAR, they won't be allowed to do a lot of treatment activities that are allowed in CAR. And this requires some alignment. Obviously, some monitoring and evaluation tools need to be aligned as well. But most of all, what we are looking now is to identify these villages in CAR side and on Chad side, and provide information to community health workers where they can look for support. So we can tell them, if you go to these villages on the other side, you can look for another counterpart, a community health worker, or you can look in our bases for mentor support, and we will immediately support you with the drugs and RDT that you need to start your work again. But more than that, we want to ensure that before the departure, and we are talking about the conflict situation, so they don't really have time to pack, that they have all the materials they need to support their communities while they are on the run. So we are now thinking and designing these light packages where they can pack some basic drug kits, some basic prevention messages, and when they move with their communities, they can ensure the communities are supported on this kind of prevention and treatment measures. And of course, one of the tasks we are performing now is really to identify what are the major villages where the refugees or displaced people settle if they have to run. And this is a work that is done with existing community health workers to identify where we need to respond if there's a major displacement. So again, it's working on preparing the field if something happens. Of course, if something happens again, what we are preparing the communities is to alert our teams to respond to refugee movements so that we can stockpile some drugs, some RDTs in advance and respond before some major outbreak takes place. Obviously, if something happens, we will supply the community health workers with drugs and RDTs, but that depends also on the need that is identified. Because if the community health worker is moving with a small community into a community that already has a community health worker fully performing activities, so there's no need to have two community health workers that potentially come up and bring some conflict. At the same time, we need to identify if the host village and the host community health worker is willing to provide healthcare to the new arriving refugees. Our experience in the project we are currently implementing in Chad is that community health workers are pretty much fine with supporting these new refugees as long as they are supported with tests and RDTs. So in brief, because I'm on my time already, there's a couple of key messages from this presentation. So the first one is, yes, it's totally possible to set up and to maintain a community health worker network in emergency conflict scenarios, as long as we ensure that all the supply, all the supervision is kept, even during a period where people are on the move. It's obviously very challenging, and of course, it's not a stable program, so there's a lot of adaptation and creativity that needs to go along with it. And that means that the costs are also increased, because sometimes we need to rent boats, and we need to rent some different approaches to reach these populations and to look for them in the bush, for example. And but again, I mean, the lives that are saved are worth the investment. So we need to think a little bit out of the box sometimes and understand that a very static approach may not be enough. And of course, setting up these kind of programs like these cross-border programs is very challenging because we are working on preparedness. So we need to convince donors and governments that we are working on something that is about to happen. And as Nathan said, in contexts like CAR or South Sudan, they are very likely to happen, but we cannot know when. In any case, working in this prevention kind of way of working may save a lot of lives later on because the community health workers are already there and ready to respond. I think that's it. Thanks a lot.